Welcome to the Kirschner webinar, the Regenerative Cell Therapy for Erectile Dysfunction, the Erectus Shot. Here with me, we've got a couple doctors in the house with me today. We've got Dr. Martinez who's here with us, but we also have Dr. Carlos Mercado, who will be presenting our webinar. Dr. Mercado is double board certified in family medicine and geriatrics, along with certifications in cosmetic and liposuction surgery and stem cell fellowship with the American Academy of Anti-Aging. He was recognized as one of the best doctors in America in 2015. He's the pioneer of eternal MD regenerative cell procedures. He's trained in both cosmetic and orthopedic procedures, and he's the inventor and creator of the Erectus Shot procedure for erectile dysfunction using regenerative cells derived from adipose tissue. With that, we're going to go ahead and get started. Dr. Mercado, it's all yours.
Well, thank you everybody for listening to this webinar. And basically, we're going to be talking about the ED and actually the present options actually for treatment. Probably as we know, currently there is not a cure for ED. So the objective actually of the seminar is really to try to find a solution for ED, actually try to find a cure for this devastating condition. As you can see in this slide, probably right now I'm from Colombia, and this is actually Cartagena. And actually, at this point in time, we're having actually a laboratory actually being built there in Cartagena, Colombia, as well as a clinic. One of the questions that most of the time happens is, okay, what can I do for patients with ED? And as we actually know, the statistics actually are very devastating. Also important to remember that the ED can be a manifestation of a coronary artery disease. So many times it's important to do the proper evaluation for this type of treatment. One of the things that I'd like to mention is that before even to get into the treatments available for ED, it's important to recognize and actually to evaluate and understand how the erection happens actually in the male humans at this point in time. I think that there is actually a misconception about the pathophysiology of the erection process. So it's important to remember, and actually they have been discussed many times, is that the erection process is a very complex process. It's just not having actually blood coming into the corpus cavernosum. By the way, there are two corpus cavernosum, one on the right side and one on the left side. The important thing to say actually is that the blood actually comes into the corpus cavernosum. I call it the Panama Canal, okay, in which actually blood comes into the chambers and then people actually achieve the erection. But in reality, it's actually even a very complex mechanism that actually incorporates actually the brain, actually incorporates the sympathetic system, the parasympathetic system at the same time. Something like you can see in this slide, actually the penile organ actually is an organ that in my opinion should be treated by a cardiologist, and it shouldn't be treated by a urologist, because as you can see, the corpus cavernosum actually is probably the area in the body that contains more endothelial cells. And that's what I tell people who smokes: if you want to kill the corpus cavernosum, you smoke, because actually you are going to kill all the endothelial cells. And remember, the endothelial cells are present in all the blood vessels, but also try to correlate the importance of the endothelial cells into the heart, into the coronary arteries. Now, the way that the erection process actually happens is that, of course, you are going to have a blood influx into the corpus cavernosum, but the corpus cavernosum basically is a bunch of sinusoids. Actually, like a group of veins all together. When you put all the sinusoids all together, actually the representation would be like having an IV axis. And that was a way that I developed the Erectus shaft. Imagine that the corpus cavernosum is actually like having an IV access. It's like, I don't know, in patients, pediatric patients, you use the bone marrow, the tibial access to give IV fluids. In a CPR state, actually, you can use theoretically the corpus cavernosum actually injecting stem cells in there, and those stem cells actually can go into the systemic circulation. So imagine the new concept or the new proposition is that the a corpus cavernosum is like an IV access, okay? So what happens is that once you get the blood flow in there into the corpus cavernosum, it's going to be a constriction into the veins. And then once those veins are compressed, basically the patient is going to have an erection. So usually what happens is when when there is not erection process, actually these sinusoids are in contraction. And when they are in relaxation, then there's going to be blood flow in there, and then the patient is going to have actually an erection. Now, I'm going to show here a little video of the liposuction, because that's the way that we extract the adipose tissue in the office. And as you can see right now, this patient probably appears like he's under general anesthesia, but this is basically a patient that I'm doing in my office, okay? And basically I'm using the water-assisted liposuction, as you can see. Whoever sees that video probably is going to think that this patient is under general anesthesia. Remember that the main complication of liposuction is general anesthesia. So this patient right now is basically alert and awake, but basically they have the anesthesia, what is called the tumescent fluids, being already pre-injected into the fat tissue. So the liposuction process in this procedure is very important, but in reality, we are not doing liposculpture. Most of my patients actually do liposculpture, definition, apps, and all that. But for this procedure, really, what you need to do is basically to do a little extraction, maximum 60 to 100 ml of fat, which actually I'm going to be talking about that later on. But the main point is that the fat harvesting is a procedure that really any physician actually can master. The way to do it is basically putting tumescent fluids, and the patient actually will be alert and awake, and the procedure can be done as an outpatient procedure. You don't need general anesthesia, and actually can be done actually properly if you set up your room properly. And again, I'm going to be talking about that in a second, describing actually the Erectus shot technique in a second. So remember a little bit of the stem cell basics. You don't need to be an expert in stem cells. I mean, we have a complete full lab in our office, but for the Erectus shot processing, really you don't need to be a stem cell expert. Just only the main point right now is that we use the fat because this is probably the most abundant source of mesenchymal, or we call it mesenchymal stem cells. And actually, there is a new term right now, it's called a vascular stem cells. Actually, the way that we do the liposuction or the fat harvesting, we're using the water-assisted liposuction. You can see actually even these blood vessels attached to the fat cells, which is a good thing, because when you are doing, let's say, a fat transfer, this is what you want to see. You want to see actually some type of a blood vessel in order to integrate the fat into the other tissue is going to be actually adapted. Now, this is a very, very important slide actually, in which actually showing that the once, for example, we do a fat transfer, okay, or actually after we do a fat processing of the fat to obtain the stem cell, what is going to happen? You are going to have 3 layers. You could see right now, the yellow one are basically a surviving zone, which basically contains a live adipocytes. Then you're going to see like a yellowish, a little bit less yellowish, like a orange. And actually this is the regenerative zone, in which actually some of the adipocytes die, but then the stem cells survive. Okay, and then the dead adipocytes are replaced with new ones, and then you have in the middle, like I call it the nucleus, in which basically is the necrotic zone. Basically, the above the adipocytes and the stem cells die. So the idea is when you do a fat transfer, some of the adipocytes are going to die, but then you're going to have the regenerative zone, which basically going to create more adipocytes. Okay, very important concept is how stem cells work, because I believe there is a misconception about how the stem cells work. Presently, we all believe that probably the stem cell doing the work directly into the tissues. For example, in the ED, something that we might think that happens that the stem cell goes in and they cause differentiation into a new blood vessel formation, angiogenesis, or actually forming new endothelial cells. Um, the new proposal is that really is not the stem cell doing the work, is probably the secreting substances produced by the stem cells. In other words, this is what we call the trophic effect or paracrine effect. Basically, for example, in the case of ED, we inject the stem cells into the corpus cavernosum, and basically what is going to be doing the work is the paracrine effect. Basically, all these substances actually that can actually cause angiogenesis, and actually it's an anti-inflammatory effect. But usually what happens is, in this slide what is showing is the systemic administration, and there is something called the distal homing, the local homing. Really what it means is that the stem cells tend to go to the area that have been damaged. This is a very important concept because we want those stem cells actually to go in those areas. Now, in the case of ED, usually what happens, as you can see in this slide, is that once the stem cells are injected, basically part of those stem cells are going to go to the what I call it the CPU of the nerve, or the ganglion of the nerve, in this case the cavernous nerve, and basically from there I start repairing the cavernous nerve. This actually happens in patients after radical prostatectomy or patients after radiation to the prostate, because what happens is after the radical prostatectomy or radiation is going to be a damage of the cavernous nerve. But remember, every nerve has something called the ganglion, what I call the CPU. So what happens in the setting of ED is that once we injected those stem cells, they go to the ganglion. Part of those stem cells will go in there and start repairing the nerve. Actually, I'm going to be talking more about it in a second, about what happens in patients after prostatectomy and radiation. Now, after that, the other stem cells actually will go to the bone marrow. And then from the bone marrow, they will continue the regenerative process, basically sending signals to other areas, even actually the pancreas. And actually, one of the things that the Erectus Chat actually cause actually is improvement in a blood sugar, as well as a hemoglobin A1C, which actually I'm going to be talking about in a second too. It's a very, very important concept, and that's actually one of the main objectives of the Erectus Chat, is probably to use this treatment in patients with new onset diabetes. Now, something that happened also is that actually this slide represents what I was talking about before, in which once we inject those stem cells, which actually is equivalent as having an IV. So injecting stem cells into the corpus cavernosum theoretically is the same. Well, not theoretically, actually in reality, it's like injecting any fluid intravenously. So this is a very, very important concept because we are using the corpus cavernosum as an IV line. The advantage is that it's a little bit slower, but then we can retain more of the effects of the stem cells in there. But again, like I mentioned before, in reality, it's not really the stem cell doing the work. It's the substances that secretes that really is going to cause the effect into the ED as well as in diabetes. Now, having said that, the most important thing really to remember is that those part of those stem cells actually will travel to the bone marrow, like I mentioned before, and then from there, they will continue sending signals to other areas like the pancreas. Now, the average in some of the studies, actually, even though in the Erectus chat, actually we use probably more cells, probably like around 50 to 60 million stem cells. The average stem cells that actually have been doing the studies have been around 1 million stem cells. But remember, it's not the amount of stem cell that counts, it's actually the substances that secretes those stem cells. Okay, now what we call the SVF, or what is called the stromal vascular fraction, is actually what we obtain after processing the fat. I know that many people right now probably never been exposed to stem cells, but really what happened, very simple, is this. After we process the fat in the lab, we're going to get the pellets, and this pellet actually is so small, and actually I'm going to have a picture right now in a second, that actually you cannot even see. But the pellet basically contains approximately 250,000 cells. And those cells actually are mesenchymal cells, they are pericytes, they are supraadventitial cells, they are actually what we call it endothelial progenitor cells, adipocytes, fibroblasts, and they have the capacity actually to differentiate. So in reality, the patient is not only getting stem cells, but also getting what we call the soup. It basically is a bunch of other cells that also have the capacity to regenerate or differentiate into other cells, and also they have the capacity to be immunomodulator as well as anti-inflammatory. So remember, people talk about the stem cells all the time, but in reality, the SVF, or the stromal vascular fraction, is more than that. It's not only stem cells. So again, that's what I said. That is a misconception, because people, when they said stem cells, in reality, I think that the term should be changed. It shouldn't be called stem cells. It should be called, I don't know, something else. We might need to call somebody marketing to come up with a good name. But because in reality, patients are not only getting stem cells, they're getting more than that. Now, we know that those stem cells, once they are injected, they go into what is called the differentiation process, meaning that they can become actually endothelial cells, they can become actually adipocytes, and really any kind of cell depending on the needs. Now here, this is the technique actually of the Erectus chat, in which basically, well, actually in this case, actually I'm just doing a little demonstration here with the Erectus chat technique. By the way, this Erectus chat technique, there has been nothing described in the literature since 1964 until 2015. So actually my technique actually was approved just now recently for publication, describing actually the Erectus chat technique, which actually in that way, we have validity for this procedure compared to other procedures in which basically they have no validity. Actually, that was a peer review article in which basically we describe the technique exactly at this point in time. The second portion of the research actually will be talking about the safety of the procedure, which actually we already know that so far the safety in all the cases that we have been 0%. So the safety basically zero. If you get the proper training on the technique, really the possibilities of, I don't know, complications actually would be very minimal. Actually, the one thing that we have seen so far in the patient that we have done is perhaps a little bit of bruising, but in reality it has nothing to do with the technique. As some patients, they have superficial veins more enlarged. As for example, patients who take Viagra and all those medications, they might have a little bit of engorgement on the veins, and then when you are injecting, might cause a little bit of bruising, but it's very temporary. So we haven't seen any priapism, we haven't seen any sepsis, no, nothing really. based on the data we have gathered so far. So the safety basically is 0%.
It's 100%.
I mean safety. Just true. Yeah, thank you. So safety, I mean, no issues actually with safety. Now, who is a candidate for the Erectus shot? In reality, any patient with ED, we use it in the patients after perionic disease. We're going to be talking about perionic disease, which is basically deformity of the penis. Also, patients after prostatectomy and radiation. By the way, patients after prostatectomy and radiation, there is a huge population right now in which basically these patients they have ED. Most of the time, the issue hasn't even been discovered with the urologist. Actually, new recent studies show that the patients were not aware that after the prostatectomy, they're going to have ED, which actually was just a recent study just now in 2016, talking about the lack of information given to the patients after the prostatectomy. And the other set of patients, the patient with perionic disease, in which basically is a plaque formation into the penis, in which the patient has like a crook penis, but at the same time, this patient also have a high association with ED, which seems to be due to a vascular process. Now, very important to talk about the ED because remember, the Erectus shots, okay, is not the solution for everything because that's, again, another misconception. People feel, even physicians actually, that they say, oh, how good it works. Well, this is no different than giving a patient a blood pressure medication. And it actually sometimes I'm puzzled because the patients or even the doctors ask me, okay, can I talk to patients who got the procedure done? I don't know, can I talk to somebody, how many patients have you treated and what is the percentage of patients who got recovered ED? However, I don't see when the patient comes to see a cardiologist, if they ask them about I don't know, this type of medication which are very little, the Pradaxal, all these medications that cause lethal bleeding, they never ask the cardiologist. If they want to talk to a patient who have been placed on a Pradaxa or those lethal medications. However, for stem cells, even the physicians and the patient, they ask about it. So to me, it's actually a puzzle. And the answer to that is very simple. It's the same thing as any therapy. This is not a panacea. Okay, this is not going to cure everything, just only to give it an injection. All depends on the patient. And the example that I put to every patient and physician is very simple. Depends on the damage. If your car has been damaged, have been for 20 years, you are small, you are obese, you have hypertension, you got diabetes, you don't take care of yourself, okay, the damage is going to be more severe compared to somebody, let's say, who exercise, has a low glycemic diet, has a low BMI, has a low visceral fat component. So that's a way really, that's the answer to all these questions, okay? Now, we are basically setting up right now specific data to show to physicians and to patients. But in reality, at the end of the day, the data is going to show that, the same thing. So what I'm saying is, when you are evaluating a patient with ED, okay, you just don't go and inject the stem cell. You have to do a full evaluation. And that's why it's important, the training of ED. So it's important to recognize, okay, the risk factor, for example, high blood pressure, dyslipidemia, diabetes, okay, lack of nitric oxides, smoking, and all that. So it's very important to do a proper evaluation on ED. In some patients, I tell them, say, listen, you are not a candidate for this treatment because most likely, I mean, your corpus cavernosus is totally destroyed. You smoke all your life, you continue smoking, you are obese, you don't take your medication, you don't eat properly. So I'm not going to give you a treatment because then you're going to say in 3 months or 6 months that the treatment didn't work, but you continue abusing, I don't know, smoking or alcohol, or you don't take your medication, you don't take care of your diabetes. So it's very important to control the risk factors. This is very, very important what I'm saying right now. Okay, the treatment will help you, but also there is a degree of the damage that being actually caused by the disease process. Now you can see right now it's very common. I mean, many causes of ED, vascular, diabetes, medications, beta blockers, SSRIs, antipsychotics, pelvic surgery, neurologic causes, endocrine problems, etc. Now, presently, the treatment for erectile dysfunction, really, if you could see it right now, the first line of treatment is basically psychosexual and couple therapy, lifestyle modification, weight reduction, smoking cessation, physical exercise, testosterone supplementation, and then you can combine that one with PDI5 inhibitors. I'm going to be talking about the PDI5 inhibitors. I have nothing against with the PDI5 inhibitors, actually. However, the way that they work, the humans have to make a nitric oxide. If you don't have nitric oxide, like in patients, let's say, with diabetes of patients after with diabetes, the slide move here. Patient with diabetes or patient after prostatectomy, for example, what happens is that the patients have a minimal amount of nitric oxide, because I believe there is a misconception that the PDI5 inhibitors increase nitric oxide. That's a totally, actually, misunderstanding of how this medication works. If you don't have nitric oxide production in your body, in the corpus cavernosum, by the endothelial cells and the smooth muscle, actually, or the corpus cavernosum, actually, this medication won't be effective. And that's the reason you see a high failure rate in patients after prostatectomy or radiation or diabetes. They don't make too much nitric oxide. So consequently, what you will see, the patient might be taking Viagra, I don't know, 25 milligrams initially, then they have to be taking 50, they have to be taking 100 milligrams to 150, 200, and escalating up. So that's actually the way, actually, that I know if somebody is making nitric oxide or not, regardless of the disease process. So I asked them, okay, are you taking Viagra? Does it work? He said, no, it doesn't work anymore. Before I used to take 50, I now taking 100, then 200, and then it stopped working. Then I switched to Cialis, and the medication doesn't work. Okay, why? That indicates to me immediately that this patient is not making nitric oxide. Why they are not making nitric oxide? One, the most common, several causes. It could be diabetes. Okay, that hasn't been taken care for a long time. It could be actually after prostatectomy, patient with obesity, patient with hypertension, hyperlipidemia, smokers, they don't make good nitric oxide. Okay, nothing against the medication, but that's the medication actually works. Some of the things that you see after the stem cell treatment, in the way for me to know if the medication, the stem cells are working, I ask them, I put them back on the PDI5 inhibitors in the Viagra. I say, okay, try Viagra now and see what happens. If the Viagra never worked before and now they take it and they see an improvement, that indicates to me that the stem cells is working. You don't need to do any specialized test or anything. That's actually a good way. So what I'm saying is I'm not against these medications, because people have said, oh, you are against the Viagra. So I'm not against Viagra. Actually, I use the Viagra as a way to test the patient and actually to complement this treatment. Now, currently, if that fails, the PDI5 inhibitor fails, then you go to the second line, which is basically the intracavernosal injection, the intraurethral injection, the vacuum, or combination therapy, basically using the papaverine, or this combination called a trimix. Now, if that fails, then you use the patient basically has to be eligible for penile prosthesis. Now, remember, very important what I'm going to say right now. Most of the studies that have been done with stem cell for ED, most of the patients are actually in the waiting list for penile prosthesis. And all the data has shown an improvement in ED. I want to make that very clear, because that question I know is going to be asked in a second by the people listening to this webinar. Most of the studies, actually all the studies, have shown that all the patients in the waiting list for penile prosthesis, they have been on the waiting list, have been in the waiting list for penile prosthesis, and they have the stem cell treatment performed. And all of them, they have shown improvement. Okay, and the way that that's done is actually by peak velocity. Usually what happens is when somebody has an ED, the peak velocity is actually around 20, 22. Okay, after the treatment with the stem cell, usually they go to 70. Normally, in a patient who got no ED, usually go to 100 millimeters of mercury. Okay, this is a very, very important. They have been replicated and replicated and replicated. Something that I forgot to mention is the fact that what happened to stem cells once they are injected into the corpus cavernosum. And that's actually a very important question in my mind. Probably many people don't think about it, but in my mind, to prove how the stem cell work, okay, which, like I mentioned before, is not the stem cells, okay, the substances released by the stem cells. There's a recent study actually showing, done by nanotechnology and MRI, in which basically showing that the stem cells remain into the corpus cavernosum around 4 weeks. Previous study has shown between 1 hour up to 4 weeks, but this recent study actually in 2015 showed that they remain approximately 4 weeks, and then after that they actually dissipate. Again, that proves that the mechanism of action of the stem cells in ED is not the stem cells. It's actually the secretion of the paracrine substances. Again, based on that, do we see more differentiation of the stem cell? Part of it might be happening too, but the main mechanism actually the secretion of these substances which have a paracrine effect. Now, here this is basically what I just mentioned before. The vacuum, the penile implant, the satisfaction rate with the penile implants is 98%, which is actually expected. You can have an erection at any time pumping any type of device. Okay. I mean, you can use the yohimbine, the horny goat, actually to improve testosterone. That's another thing also, actually, what I'm going to be talking about in a second. It's important to, in the evaluation of ED. Remember, when you are evaluating these patients, okay, it's not like you're going to do the shot. You need to do a proper evaluation of ED. Which actually we have a protocol for that. We have a protocol for the evaluation, for the physical examination, and the blood test also that needs to be performed. This is very important because you don't want to create false expectations. Okay, somebody, I'm going to make an analogy here. If somebody has a CHF and the ejection fraction is 10%, okay, and you're going to say, well, we're going to do stem cells, yeah, you might improve the ejection fraction at some degree, but you need to set up the proper expectation. You might tell to that patient with CHF with ejection fraction of 10%, listen, well, we might need to do, I don't know, add something else to the treatment, or probably at this point in time, the stem cell might help you some degree, but it's not going to be the 100% because you already damaged everything. Okay, so the more damage is in the corpus cavernosum, endothelial cell, corpus nerve, cavernous nerve, it's going to take more time to recover. And if you continue with bad lifestyle, then of course it's going to take more time. Now, it's very important to recognize that the statistics, okay, and this might be shocking to you, but this is the reality. In 1995, in the planet, there were 152 million men affected. And again, I don't know if this number is because people at that point in time, 1995, they didn't talk about ED, but it's projected by 2025, 322 million men will be affected by ED. At this point in time, it's very simple. There is no treatment available now for ED. All these medications, the PDE5 inhibitors, the papaverine, all those medications, they don't cure ED. It's the same thing as there is no cure for diabetes. We got, I don't know, every time I turn the television, I see a new medication that I cannot even pronounce the name because the names are so difficult and I don't know where these names are coming from. So the same thing actually is happening with ED. There is no cure. So the idea with this treatment really is to try to find a cure for ED. I mean, the present protocol that we're going to describe in a second will be actually disclosing the part of the technique and part of the processing. Again, my point is that you don't need to be an expert in stem cells actually to perform this treatment. This is a treatment that actually can be done actually in the office setting. Now, currently, the overall failure rate with all the treatments, all combined, is 20%. However, in patients with diabetes and radiation and prostatectomy is 40%. Okay, so remember the PDE5 inhibitors, they are not able to reestablish function. What they do basically is cause a vasodilation, okay, but you need to have nitric oxide. If you don't make nitric oxides, then the medication won't be effective. And the idea of the stem cells actually is to improve the production of nitric oxide via the corpus nerve and the endothelial cells. So remember that concept, very important. The idea, I'm going to repeat it again, is to improve the production of nitric oxide through the cavernous nerve that have been damaged after prostatectomy or radiation or diabetes, okay, or the endothelial cells at the same time. Now, in our protocol, we use what is called the ED intensity score, which basically we evaluate the patient and actually assess the severity of the ED. And actually, this ED intensity score has been validated. And basically, from 1 to 7 is severe ED, 8 to 11 moderate, 17 to 21 is major, 22 to 25. I advise actually everybody, the conference, to take the test. Because sometimes, we feel we are okay, but then when we take the test, we might notice some deficiencies, and then we actually look for some type of help. Now, a common question, and I have been doing this, conferences and webinars and all that for a while, and a common question, show me the data, especially here in this country in America. They say, oh, show me the data. I want published data. I want this. I want that. And basically, all these things basically have come from the pharmaceutical companies. And I have to be honest, most of these pharmaceutical studies, actually, you could see the FDA rejecting medications, or people actually dying after these medications have been approved. The only thing I can tell you for sure is that this treatment has no side effects. Okay, there are no complications from this treatment. We haven't seen any. It's zero. Okay, compare, let's say, if you take an aspirin, you can have a GI bleed. If you take an NSAIDs, you can have actually kidney failure. Actually, 18,000 people die every year in this country just only taking over-the-counter NSAID being bought at 7-Eleven. Okay, so when I'm talking about this treatment, really the complication rates at this point, what we have been seeing is 0, 0, 0, 0, 0. Of course, you have to, get the proper training, get the proper evaluation, patient selection. Now, the studies that everybody wants to hear, oh, I want to see the data, blah, blah, blah. In reality, we got approximately 35 actually preclinical data studies. We got in different settings. We got in patients with damage to the cavernous nerve. We got 20 plus studies. We got 10 studies basically in diabetic patients. We got 6 studies in patients who got just ED. Okay, these are all preclinical data, and the preclinical data basically show that the improvement in the ED, okay, improvement in the peak velocities, all the data. Actually, I don't know if I should say this because I don't like to be biased here, but you can go to my website and you can see actually all the published data. This is like, okay, okay. The coordinator said this on a slide after this, talking about the published data, which actually you can find it all in there. And again, here right now, this is just a recent study, actually, 2016. I'm basically talking about safety of the study. And actually, this study basically show the same thing that I have been saying before. Okay, this is basically a complication rate basically is 0%, which actually in general applies to almost every type of stem cell treatment that is a adipose derived. Okay, actually you can use in the ED setting. You can use umbilical cord. You can use IGF-1. We just actually, something that I cannot mention right now here because they are proprietary information. Basically, so that we're working on the lab in the last couple of years for ED. But the main thing that really physician needs to know on patient that is safe. The procedure is very safe. Of course, you have to do, the proper training and all that. Here you got all the studies. If you have insomnia, you cannot sleep at night, you can go and read all the studies, actually read all of them. We got for, diabetes, for after prostatectomy. Now, this is what I was talking about the offset at the beginning of the conference. Is I'm going to put this case study because this is probably going to answer most of the questions that I'm sure that people want to ask right now. This is a 65-year-old male patient. The chief complained of ED for the last 6 years. That worsened after prostatectomy due to prostate cancer. The patient is a smoker, heavy smoker, hypertension, diabetes, obesity, dyslipidemia, sleep apnea. By the way, very important, patient with ED, okay? You need to make an assessment for the sleep apnea. Something that happens physiologically in sleep apnea because eventually this patient, depending on the degree of sleep apnea, this patient might develop chronic hypoxia, okay? The chronic hypoxia is going to cause vasoconstriction in the blood vessels, and that's basically a leading factor actually for ED. So one of the protocols actually we have been working with actually using HBO, actually in the setting of ED, even without the sleep apnea. That's something that later on we can present some data on that subject at the same time. But remember that the sleep apnea is something that you need to evaluate to. Don't forget if somebody is not, please send it to a sleep study, send it to a cardiologist if you feel that the patient has many cardiovascular risk factors. Again, this patient that I'm showing right now really is a patient that probably you see almost every day. Okay, obese, hypertension, diabetes, they don't exercise. By the same token, they are taking this medication to counteract the high blood pressure, for example, beta blockers. Remember that the beta blockers, the mechanism of action, the way that they cause ED or actually worsen ED, is that because you block the beta blocker receptors, then the alpha receptors actually take over. Remember, in order to have an erection, you have the sympathetic and parasympathetic system. So it has to be an equilibrium between the two of them. So now, if you need to have a relax. Remember, you have to be relaxed to have an erection. Okay, so if you got too much sympathetic system, it would be more difficult for you to have an erection. Okay, SSRIs also are associated with ED. So, I mean, to make the story short, in this patient, basically what we did the mini liposuction, usually 60 mL of fat. Is done in the office, no general anesthesia, the SBF is obtained, and then I'm going to show you later on the technique. But basically what happened in this patient is improvement in penile sensation, spontaneous erection in the morning. That's another way too. Many patients, they don't have erections in the morning, and after the treatment, they start noticing more erection in the morning too, and also the ability to decrease the amount of Viagra. By the way, we did a study. The amount of Viagra men consume in the United States is approximately they spend a year between $3,000 to $6,000 a month. I mean a year. Okay, remember that number, between $3,000 to $6,000 a year, even with insurance. Okay, this is probably part of the, this is a study actually done in Spain, actually in March of 2015. These were patients actually who got diabetes, and actually they were in the waiting list actually for penile implant. They got the SPF, the stem cell treatment into the corpus cavernosum, and basically what happened, like I mentioned before, most of the patients, all of them actually, when they were interviewed, they said that they have a significant improvement in their erections, okay, and also the peak velocity is actually improved too. Now, the common question is why the blood sugar gets better, okay, and actually there are two mechanisms of action. One is the early phase, which actually the stem cells promote the beta cell function, and the late phase, which actually improve the insulin resistance, and actually mediated by the GLUT4 expression and an elevation of phosphorylated insulin receptor substrates. So for sure, what we have been seeing is that this patient, the blood sugar gets better and the hemoglobin A1C actually gets better. Okay, actually this is probably very important slide because that shows what I have been telling you before. If you can see right now the cavernous nerve, I want you to identify the cavernous nerve right now. There's a way to point it out right now. Okay, this is the cavernous net right now making nitric oxides. Okay, and you can see right here the endothelial cells. Oh, you can make the endothelial cells actually making the nitric oxides. So what I'm saying to you is that you need to have nitric oxide in order to have the PDI5 inhibitors to work. That's the main concept. Now the other one that is not dependent on nitric oxide is a papaverine. The papaverine basically is what people call that it's a combination trimix, which is basically independent of nitric oxides. So most of the patients who got prostatectomy or radiation, most of them most likely must have been on papaverine. The problem with this medication and the risk actually is the problem with priapisone. Okay, some patients react very badly and very painful erections with this medication. Okay.
Sorry, we're having a bit of a technical problem.
Okay, so remember that the importance is this: the Viagra and all these medication, PDI5 inhibitors, you need to have the formation of nitric oxide in the body. If your body doesn't make nitric oxides, then the Viagra won't be so effective. Now, the because I believe very strongly it's a misconception. I don't know where that thing came from, in which they said to even patients, I mean, doctors said to the patient that the Viagra makes nitric oxide. Viagra doesn't make nitric oxides. Okay, if your tissues are not healthy, your body won't make a nitric oxide. Now let's talk a little bit about the perionic disease, which actually affects 7% of the general population. Many people have a crooked or deformed penis. And the problem with that is that in some patients, depending on the severity, the erection can be very painful and cause actually even some patients even bleeding actually. Not only that, one of the issues is that these patients, they have associated ED. And actually there are two studies. There's a study by Lopez, in which basically he showed that 80% of the patients had associated ED. Okay, and he showed that probably most likely is a problem with vascularity. So remember, patients with perionic disease, they may have a problem with vasculogenic ED. Okay, now when we inject the stem cells in patients with perionic disease, okay, you don't, well, let me go back a little bit here. You don't need to inject the stem cells into a plaque. That's number one. Okay, because I see in some of the protocol people injecting actually stem cells into the plaque. You don't need to do that. The reason being is because, again, you need to go back to physiology. The way that the stem cells work, I already said it before, is mediated by the release of trophic substances. Okay, so really what's going to cause it going to be like an anti-inflammatory immunomodulation effect, which is basically eventually is going to dissolve that plaque. Remember that the surgery that is done currently for perionic disease is a very devastating surgery, in my opinion, because remember, the plaque, what is the plaque form? It's a very thin layer, which is called the TA, tunicus albuginea. It's a Latin name, tunicus albuginea. It's a very, very thin layer in there. So if you try to remove that plaque, guess what is going to happen? More scar tissue, more fibrotic tissue. So the way that the stem cell work actually in the periodic disease is trying to immunomodulation, anti-inflammatory effect, and then eventually the plaque will go away, and then the penis will straighten actually, and then the ED, the vascular ED will improve. This is basically showing you what is called actually in the preclinical data, actually the MPG, okay, which is called the major pelvic ganglia. This is in preclinical data showing that basically we got two corpus nerve actually that runs along the prostates, one on the right side and one on the left side. The prostatectomy, even with the robotic surgery, inadvertently, most of the time what happened, there are two mechanisms, the crushing mechanism or dissection mechanism, in which basically there is a dissection of the corpus nerve, and then consequently the nerve is damaged, and then no nitric oxide. Again, I go back to the nitric oxide again. You are basically damaging the nerve, and there is no nitric oxide. Now, what happens really once the damage of the corpus nerve happens, is going to be Wallerian degeneration, no connection with the corpus cavernosa, no release of nitric oxides into the corpus cavernosa, no engorgement, and then this is going to lead to hypoxia. The hypoxia basically going to lead to the smooth muscle cells have been replaced by collagen. In other words, the penis become collagen. That would be good in the face, but not in the penis. Now, there are many models actually in preclinical data actually that demonstrate this actually mechanism of action, and that's actually the reason that the PDI5 inhibitor, they have difficulty working properly, because you damage the production of nitric oxide.
So we want to open it up to questions in a minute, but I also wanted to thank Dr. Mercado for his great experience and information. He does have some hands-on training opportunities. They're up on the screen here, and you are going to get a survey at the end of this webinar. And in that survey will be links to his webpage that has more information about the training and more information, again, about the Erectus shot. So the next training session is coming up April 8th. The last thing we wanted to show you is an animation of the Erectus shot. Is it okay?
Yeah, that's fine.
Okay. Just to kind of give you an idea of how this works.
This animation will depict a stem cell harvesting procedure.
I just wanted to mention a little bit of the, I mean, whoever wants to come to the training, that's actually your decision, but some of the things that I noticed actually a lot in this country, in America, is that these courses, actually, most of them, there are people going and being like an observer. They don't do anything. They just go in and they watch, which actually I'm puzzled by that, because they call it hands-on. This course actually will be limited only to 5 to 6 people at the same time, and includes actually performing liposuction, okay, basic liposuction, how to harvest the 60 ml of fat. Number 2, includes also the stem cell fat processing. At the end of the course, you'll be able to process a fat sample, and also you'll be able to process a blood at the same time. So let me just go back a little bit of, I mean, I don't know if I'm being, I mean, too strong into this, but something that really caught my attention at the courses of what people call hands-on. I mean, you go to this course, and I've been, I don't know how many, and you basically are an observer. You are just watching. You are just watching what the doctor does. This course is only limited to 5 to 6 people at the same time. And the reason it's limited to 5 to 6 people at the same time is because we want, by Monday, okay, when you go back to your office, actually to perform this treatment, okay? Now, the course entitles, okay, the liposuction technique, okay, the anesthesia. You'll be able to do it because we have too many patients hands-on that you'll be tired. Actually, the last course that we just did in February, people just didn't want to do it anymore because they were tired, and that's the idea. Entitles also the FAB processes in the lab, how to set up your own mini lab in the office. We can actually provide you with all that too. The digestion system, as well as the technique, as well as the anesthesia to the patient. The other thing also too is that this procedure actually have been trademarked. So you'll be able to use actually the name Erectus Chat. Only the doctors who come to the training actually will be able to use that name, the Erectus Chat, and they will be providers. The common thing that is happening is the following. We get many phone calls, let's say from New York, from California. I'm here in Orlando, okay? And the patient, they want to have a provider, let's say New York or California, whatever. And the idea is that basically the physician that trained into the procedure, they will be able to provide the patient. We just got, I don't know, last week we got like 3 patients coming, one from Tennessee, the other one from California, all over the place. And the main question that we're having, the main problem actually is that the patients are looking for the procedure, but there are no providers actually in those areas. So the idea really with the procedure is to develop a community, because actually this is not only something that you need for the physician, but also to create a community in which we can do research together. We are ready to launch actually our second study of safety right now on the Erectus Chat. We just got approved for the Erectus Chat technique that being published now probably at the end of March or April. But again, the idea is to work as a group. This is nothing that, you come for a training and then you say, okay, I don't see you anymore. That's not the idea. The idea here is to have a continuity, actually, to develop a peer group in which actually we can collaborate actually each other.
And one of the things that Dr. Mercado has developed is a directory. So there'll be a directory of doctors that have been trained with the Erectus shot, and as patients call in and want to find doctors near them, there'll be a doctor finder that will help direct them. A couple things, I've seen a couple questions coming in. I want to throw one poll out there just so that we can kind of see what's going on with everyone. I only see, right now it looks like about 25% is coming in. The poll was what percentage of your population are male currently. So the other questions that we have that have come up, Dr. Mercado, have to do with people that have met you at other locations before and looking for your information to get in contact with you. So I will share that after the webinar as well. And if there's any other questions that you have after the webinar, please send them in and I'll get you connected with Dr. Mercado to get you the answers. With that, I'd like to thank Dr. Mercado for being the facilitator and sharing his great wealth of knowledge. And look for a survey after the webinar, and we will get you some additional information on the Erectus shot. Thank you for attending.